Okay, so the actual policy change that comes in policy 606, this update is seen at the top of the screen there. And it's really simple. If you follow the flow chart for determining resuscitation versus determining death up front on scene, when you're following the trauma side of that flow chart, if you land at the decision to resuscitate a patient, the language is now very specific to treat per your traumatic arrest 705 policy, which is 70529, and transport to a trauma center. The reason that we have this language in there, it's one small effort to emphasize early transport in these patients. We still come across a decent amount of cases where these patients end up receiving prolonged care on scene, more consistent with CAM or a medical cardiac arrest, when we really need to shift how we approach these patients. We're going to dive into all of those concepts more shortly here, but to begin with, I thought we would quickly review the decision making. Sometimes it's helpful to think of the flow chart or the process for making traumatic arrest resuscitation decisions as what do I need to resuscitate? What criteria do I need in order to determine I should resuscitate? As opposed to thinking of all sides of that flow chart and what the don't resuscitate criteria are, as well as the resuscitate criteria. So there's two key pathways that would get you to the end answer of resuscitating a traumatic cardiac arrest. The first is age by itself. And this is really easy. Anybody who's less than 18 years old, resuscitate. You could be greater than 20 minutes from a trauma center. They could have an ugly EKG. Less than 18 years old, we resuscitate every time. So that's really easy. For the rest of them, we look at viability. So the first thing here is that we know blood and surgery are priorities for these major trauma patients. They need to get to both of those quickly to be able to potentially survive. So that's where the trauma center ETA of less than 20 minutes comes in. Can we get them to blood and surgery quickly enough to where that may allow them to have a meaningful outcome from this traumatic arrest? If the answer is yes, the next thing we look at is their cardiac rhythm. You can be providing resuscitation, some BLS measures as you assess their cardiac activity. I know it's kind of counterintuitive to bring the cardiac monitor early on into the care of a significant trauma patient. So you can be working to resuscitate if that's how it seems this will go, while you patch them up and assess that rhythm. But it is helpful to check the rhythm to consider viability. So if you think about it, the heart pumps blood from the left ventricle through the aortic valve, and the very first thing that happens is that blood gets distributed to the heart muscle itself through the coronary arteries, right, which branch off the aorta right after the aortic valve. So the heart muscle is the very first thing to get blood each time the heart pumps. We know that as you lose blood, you're going to vasoconstrict and keep that blood towards your core and perfuse a smaller amount of your body. The heart itself would be the last thing to get less perfusion. You can think of it, that's a bit of a simplification, but you can think of it that way. So the heart's activity sort of tells us how extreme their lack of perfusion is and how long it's been going on, or how much blood loss there's been potentially. Any narrow complex EKG, whatever it is, whether it's a junctional rhythm, AFib, something tachycardic, something bradycardic, if the QRS complex is narrow, that's so close to a normal conducting electrical activity that we've got to assume the heart has a reasonable amount of blood flow still being provided to it, which would be a good sign. VFib or VTAC, again, that's a lot of cardiac activity there, and also may suggest that trauma was not the cause of this whole thing in the first place. So VFib or VTAC would be a very favorable rhythm to see a patient in. And any PEA greater than 30, again, would tell you that you're looking at a pretty viable rhythm. If the SA node or whatever it is that's depolarizing is still that active and kind of irritable, or trying to compensate, that you have a heart rate that's above 30, that tells us there's still some amount of blood flow to that heart and it may make sense to resuscitate. So that's a viability-based decision making. Are they close enough to blood and surgery, and does their heart show us that it's still getting some reasonable amount of blood flow or not? If they don't have these two factors, then we don't resuscitate. In either case, if we do resuscitate, treat during transport is key. We know time is of the essence. Getting them to blood, getting them to surgery is directly correlated to their survival. We know that there are a lot of interventions that you should take in the meantime, but we know that they have to happen on the move. So we need to limit scene time to 10 minutes and transport as early as possible when the answer is to resuscitate traumatic arrest. Here's a presentation we went through in 2019 Skills Lab about, and this was prior to the standalone traumatic arrest policy, but here we cover a little bit of the thought process behind how we treat traumatic arrest patients when indicated. First question really is, what happened that made your patient pulseless? What is it about that mechanism or their injuries that can cause pulselessness? What does trauma cause that can also cause pulselessness? That's what we're looking for. And based on your patient's injuries, which of those things is most likely? So here's really, all of this is a bit of an oversimplification, but here's really what causes traumatic arrest. What traumatic injuries cause pulselessness? Hemorrhage, we know that one. So patients bleeding out, that might be external, which is great because we can put a tourniquet on that hopefully and stop that bleeding. This may be internal. We should assume that there is internal bleeding, which is more of a challenge. This is where surgery and blood and transport in our case become a priority. Pericardial tamponade, that's fixable, not in the EMS environment here, but it is a fixable problem. Tension pneumothorax, does a tension pneumothorax cause pulselessness? Absolutely. Eventually it does. Can we fix it? For sure. Should we? Yes. Neurologic injury, so think of neurogenic shock to such an extent where we now don't have a blood pressure at all. And then respiratory failure. There's some amount of these patients who will envision somebody who hits their head. They're skateboarding, they fall, hit their head on the sidewalk, and they may not have any life-threatening injury from that, other than the fact that for some period of time they don't ventilate adequately or manage their own airway adequately. And unless that's fixed, that itself will result in a respiratory and cardiac arrest. Whereas there may not have been something else that would have, some other insult from that mechanism that would have made them pulseless, other than that period of apnea. So something to consider there, that some of these may be simpler than we think. So with that pretty clear sense of what is likely to be killing our pulseless trauma patient or keeping them pulseless, and become more oriented towards just fixing problems. And if you fix a problem and the patient still doesn't have a pulse, then you sort of ruled out that problem and can move on to fixing the next one. So what tools do we have in the toolbox to address and potentially fix some of these issues as we move quickly towards the comprehensive care of a trauma center? The first is, and we'll look to our policy for the toolbox, the first is minimizing scene time, right? Making sure we are moving towards a trauma center so that they can fix the things that we can't, they can find the problems that we can't. Ultimately, surgery and blood are a simple way of looking at that. Next, while we move towards that trauma center, we have airway management. Airway management is, of course, something we're going to do for all of these patients, but we may prioritize it by addressing it earlier or addressing it more aggressively in patients where it's particularly important. One example is the more isolated head injured patient, where managing CO2 levels becomes really important for managing intracranial pressure. Another example might be a patient with clear threats to the airway, vomit or blood or something else threatening aspiration or occluding the airway currently. Next, we have needle tease. Maintaining a high index of suspicion for tension pneumothorax is critical in these patients. Instead of listening to lung sounds and kind of thinking, oh, are they slightly diminished on one side versus the other, and going through our normal approach in that sense, think of it as the fact that this patient is pulseless is the best indication you've ever seen for a tension pneumothorax being there. What we hear or think we hear is much less important. So decompressing the chest, both sides, should be on the list of treatment for every traumatic arrest. It's just a matter of where in the priority list that intervention falls. It's such a, because we know that tension pneumo by itself could have caused the arrest, could be causing the arrest, and we can fix it. It's such a high value, a potentially high value intervention that we just shouldn't pass it up unless we're at the trauma center before we get to that priority. Next, we have volume. Of course, most of these patients are bleeding, and all of them have no blood pressure. So raising that pressure through whatever means we can and replacing some of the volume lost with normal saline is not as good as blood, but better than nothing until we get that pressure, some minimal pressure back. And then lastly, we have treating cardiovascular collapse with CPR and epinephrine, meaning we're not correcting a problem here so much as helping maximize the flow of whatever blood is in there and maintaining blood flow, maintaining whatever pressure is possible with that. So it's sort of a stopgap or a stopgap effort, I guess you could say, while we are fixing other problems. But really, for most patients, isn't the priority. If we shift back over here to our causes of arrest, we need to focus our efforts on things that are fixing a problem, and included in that is rapid transport to a trauma center.